Now what I'd like to do is share some 2 real patient courses from our center with you. So this is the first patient. He is a fit 41-year-old male, was diagnosed with myelodysplastic syndrome with excess of blasts and was considered to be high risk based on these genetic characteristics. He had a female 40-year-old unrelated donor, 10 out of 10 matched, and received his allotransplant in November 2023 with myeloablative conditioning, busulfan and fludarabine, peripheral blood stem cells, as is usually the case, routine GvHD prophylaxis with cyclosporin methotrexate HG. He had risk factors, so he was colonized with a multi-resistant E. coli from the beginning. And during his hospitalization, he had stage 2 mucositis. On day 28, he had complete donor chimerism, was discharged, and on day 32, had no acute GvHD, was seen in the outpatient clinic on a weekly basis, what we usually do. Then when he came in on day 45, he basically then was diagnosed with grade 1 acute GvHD that involved only the skin according to MAGIC criteria that Michelle showed before. It was stage 2. So he received topical steroids, immediately resolved, and was then seen again in the outpatient clinic on day 80. Since he had high-risk MDS, on purpose, we started the taper of cyclosporin. And on day 109, he came in, no symptoms, but had an increase in transaminases. So we basically removed everything that is liver toxic with regards to drugs, did an infectious screen that was unremarkable besides the colonization. And on day 116, his liver enzymes further increased, and most remarkably, his bilirubin was 6.5. So in that case, since he had no infections, all liver toxic drugs were removed, he had mild thrombocytopenia. The abdominal ultrasound was unremarkable. He had no diarrhea, no skin rash. We decided to do a liver biopsy, what is not frequently done, but his main problems were obviously within the liver. And you can see here on the right side the results of the liver biopsy. So for acute GvHD, what is diagnostic is that you have damage to the bile epithelium, that you have apoptotic cells, that you have the portal fields where you have inflammatory cells, and only if it's long-standing GvHD, you have this loss of bile ducts and portal fibrosis. So a pathology report came back that it was a liver GvHD. He was started on steroids at 2 milligram per kilogram. And pretty short after, he came in with nausea, vomiting, severe diarrhea 7 times a day for the last 2 days. He was febrile, had diffuse abdominal cramps, and had lost 2 kilograms. So we did a workup with blood, stool cultures, virology, C. diff. Everything was negative besides the colonization that he had in the first place with this resistant E. coli. We then did gastroscopy and colonoscopy, what is usually done when you have the suspicion of GI involvement by GvHD. And we also have the opportunity to do stool microbiome analysis. And what you can see here on the left is the results of the endoscopy. So in the stomach, that is here, he had diffuse erythema. In the duodenum, that is up here, you can see that he had some lesions, but also edema, exfoliation of the mucosa, fibrin layers. So that all fitted to acute GvHD. And in the colonoscopy that is shown here on the right side, you can see in the sigmoid below here that he had diffuse erythema lesions, and this all fitted basically to or lower GI involvement by GvHD. These are examples how histology would look like. And you all probably know that learner grades are used by pathologists, but learner grades are not the same like clinical grades from the MAGIC consortium. So when this, we also had the opportunity to do biomarkers that were sent to Regensburg with ST2 and REX3 alpha. So he had an score of 3, means a high risk of mortality, and also a high risk Minnesota score because of lower GI involvement. So what it then turned out was that he had eventually grade 3 steroid-resistant acute GvHD involving the liver and lower GI tract. And steroid resistance was basically, he was started on 2 milligram per kilogram on day 123, and on day 126, he had no more nausea, so upper GI responded, but he had an increase in stool volume from 1400 to 2500, and no change in bilirubin. And according to our consensus criteria, if a patient has a progression of GvHD within 3 to 5 days on at least 2 milligram per kilogram, that's what you would call steroid resistant. So that was the time point where you would have to start salvage treatment. We decided to use ECP because he had a high relapse risk and he was colonized with a multi-resistant E. coli. So ECP was initiated 3 times a week on a weekly basis, and we kept him on steroids and the cyclosporin. And we do have data on the use of ECP as second-line treatment. This is from our retrospective analysis we did, Vienna, Nottingham, and Vanderbilt, where we had 128 patients included. And you can see here when ECP and steroids as second-line treatment were used, we had high overall response rates of 77%, with complete responses in 67% and another 10% partial responses. It didn't make a difference whether you had steroid refractory or steroid dependent disease. And we could then in multivariate analysis demonstrate that if you had a higher grade of acute GvHD, you had a poorer outcome with regard to 6 months failure from freedom from treatment failure, but also 2-year non-relapse mortality and 2-year overall survival. And if you had increased multi-organ involvement, you had a higher non-relapse mortality and lower overall survival, despite the fact that ECP and steroids was used. So when we then saw that the patient on day 135 basically responded with regard to the stool volume, but still had a fairly high one, so we considered this as a partial response. We then started second-line treatment and eventually added ruxolitinib, kept the patient on ECP and steroids. And with this regimen, you can then see that the patient started responding. We were able to taper steroids on day 167. And you can see here, 10 days later, the patient had already stage 1 lower GI GvHD and a complete resolution on day 205. And we then basically discontinued, meantime steroids were discontinued, and we then discontinued ECP on day 235. There is data also that was published last year from the Hamburg group, where they compared ECP plus ruxolitinib to ruxolitinib alone in patients who had advanced steroid refractory acute GvHD. This is a retrospective analysis, a total of 78 patients. And you can see here that in the Ruxo ECP combination group, at day 28, overall response is 86% compared to 90% Ruxo alone. But please keep in mind that here most of the responses are partial. If they continue treatment, for example, here to 12 months, overall response rate didn't change that much, but the CR rate increased to 64% in the combination. And in Ruxo alone, it's only 17%. But most remarkably, what is also important for patients' outcome is that in the Ruxo ECP group, that is the blue line, at 1 year, you had a significantly lower chronic GvHD rate, 24% compared to 49% in Ruxo alone. So with regard to acute GvHD, I think that we do have data from different centers, including ours, that ECP is effective as second line or later treatment option. It is immunomodulatory and doesn't cause generalized immunosuppression, has a very favorable safety profile, and can also be used in patients who do have infections, what is also important for children. And then let's come to our chronic GvHD patient. This is a fit 63-year-old male with acute myeloid leukemia, NPM1 positive, with an HLA identical sibling, a sister of 54 years available, received his transplant in December 2023, also with myeloablative conditioning, was in first complete hematologic remission, but MRD positive, received peripheral stem cells, same GvHD prophylaxis, had some mucositis and fever of unknown origin, but did well, had complete donor chimerism on day 28, could be discharged on day 33, and was monitored, had no acute GvHD, no complications, did fine. And on day 123, we monitored, of course, his PM1 levels quite carefully since he was MRD positive before transplant. He had a rise, was still in hematologic complete remission. So on purpose, we tapered and discontinued cyclosporine rapidly. And he then had a little bit of skin rash that was considered to be stage 1-2 from the MAGIC consortium, resolved on topical steroids. And we then decided to give him donor lymphocyte infusions. And in that case, it would have been preemptive DLI because he had persistent MRD positivity. And according to the EBMT recommendations, if we look at preemptive DLI and the different time points where it's given, so he was in between 3 and 6 months, you have, depending on whether it's a match-related or unrelated or haplodonor, different cell doses. So that's what we, of course, kept in mind. So we started on a dose of 5 times 10 to the 3 times 5 times 10 to the 5th per kilogram of DLI, and we had no acute GvHD. And then in January 25, that means half a year later, had a molecular complete remission. And that was also the last time when he received DLI. And then in April of 25, he started out having superficial sclerosis of the lower legs. So that was, according to the NIH consensus, moderate chronic GvHD. A little bit mild of eyes and oral mucosa. So we started him on steroids at 1 milligram per kilogram. He then afterwards developed pneumonia, was hospitalized, but this resolved. And in July of 25, his eyes and oral mucosa had a complete resolution of chronic GvHD, but he progressed to deep sclerosis or of the lower legs and trunk. And you can see basically the pictures here of the legs. And he also started having contractures of the ankles. So that meant he was impaired with his daily life activities. You saw from Michelle the scoring. So in that case, it's just important to remember Once you have deep sclerosis, even if it's a low percentage, it's always severe chronic GvHD. And then with regard to contractures of joints, there is an excellent scoring system depending on how impaired are patients with their daily life activities. And we know from the REACH3 study that led to the approval of ruxolitinib that there after week or at week 24, the ruxolitinib cohort had a significantly higher overall response rate, 49.7%, compared to the control arm. However, most of the responses were partial responses. What is important, if we look here, for example, at skin involvement, ruxolitinib 41% at week 24, and a control group 15% that would fit for our patient. For joint fascia, 37.8% versus 16%. So we basically then had the patient on ruxolitinib and steroids, and unfortunately saw in the outpatient clinic that the deep sclerosis progressed. So especially joints got worse. And in that case, we were still considering, of course, the risk of AML relapse since he was MRD positive before transplant. But we had to do something since he was very disabled. So we decided to initiate ECP because it doesn't cause general immunosuppression. It doesn't increase the risk of infections and also of GvHD relapse. There is some publications where they looked specifically at response rates of deep sclerosis to ECP that you can show here, see here. This is our first original publication where we have high response rates, and we do think because we have long treatment durations. And this is basically from a study from our group with Nina Warren. That has not been published yet, but will hopefully be soon, where we looked at 43 patients who had at least a year of ECP treatment. 54% received ECP as second-line treatment. 84% had severe chronic GvHD, and that mainly involved the skin with deep sclerosis. The overall duration of ECP was a median of 19 months, but you can see here that some patients had years of treatment. With regard to the overall response rate, we had severe chronic at baseline of 84%. And when we then looked at the different months, for example, here 12 months, this decreased to 44%. This is just for skin, since we had 84% of patients with skin involvement. And here then we looked at 3, 6, 9, 12 months. As severe, or the responses are shown up here. At 12 months, we have 27% complete responses in gray, 38% in blue partial, 30% stable, and only 5% progressed. And of course, if patients at that time point were in these two categories, we continued ECP. We do have a meta-analysis that was published last year, where they also looked at patients with steroid-refractory chronic GvHD. They came up with a lot of studies, including some of ours. And you can see here that when they looked at the overall response rate at 6 to 8 months, this is basically 54%. And what was most remarkable was that when they looked at the earlier time point, it's 3 to 4 months, this was 45%, and the overall response rate increased depending on the duration of ECP. And they specifically mention that there is clinical scenarios for long-term clinical effectiveness of ECP, or where effectiveness of ECP is better if you use it long-term. Coming back to our patient, we started him on ECP, could then taper his steroids quite soon. Here in October of last year, he already had improvements of sclerosis on trunk and lower legs. The ankles, unfortunately, remained unchanged. This January, he had further reduction of deep sclerosis, and the only area where it remained was the ankles, what is not that uncommon in clinic. But you can see here at the lower legs that the skin has improved tremendously. So at present time, he's doing fine. We continue ECP for 2 days every 4 weeks. Before the interval was 2 weeks, and then we increased it to 4 weeks. So for chronic GvHD, we do think that ECP is a good second line or later treatment option. It can be combined with other therapies. And it, especially in scenarios like sclerodermatous chronic GvHD, also lung involvement, it has more benefit if you have a longer duration of ECP.